Hello everyone, welcome to the next episode, episode 4 of our FRCR teaching, and hope the previous episode were helpful so far. Please do give us a feedback so that we can progress. Today episode we do have we're trying to make it as a real exams case. We got a candidate who want to be anonymized but is preparing for the exam in few months time, and I think we'll be glad to keep her anonymized because she wants to not get nervous if she is the candidate. So we'll start. Okay. So this is a first case. Welcome to the exam. Uh, and this is a first case, which is patient with shortness of breath.
So I'm given with frontal radiograph of skeletally mature patient looking at the bilateral hemithoracis lung fields appear normal. I can see that both the hyla are bulky and have a convex outer margin. Visualized cardiophrenic angles appear normal. The bony thorax and soft tissue appears normal. So, based on the appearance, my differential would be uh, hilar masses. It could be nodal or vascular. To confirm my findings, I would, in my routine practice, would like to discuss with the referring physician to have a cross-sectional image of the patient. So I would like to have a contrast enhanced CT chest for the patient.
So what is your differential diagnosis based on this?
So nodal disease, but I cannot see any parenchymal abnormalities. So my differentials would be sarcoidosis, tuberculosis, and any nodal metastasis, say lymphoma,
And which is the most commonest you think?
sarcoidosis.
Sarcoidosis. So do the patient do have some skin lesions? So does that make it more confirmed?
Yeah.
Okay. So we carry to the next case, and this is case number 2. This patient has come with some degree of shortness of breath and pain in the hands and limbs. So carry on.
So yes, I'm given with say oblique projection of the hand with wrist. Site could not be determined. So I can see calcifications in the soft tissue along the radial aspect of first of second digit and along the ulnar and interior aspect of the first digit, and some prominence of thinner eminence. um, Otherwise, the bones
You
appear.
can use the mouse to show me. Yeah.
Yeah, so there are calcifications along the IP joints in the distal second finger, and there are components of acroosteolysis and some calcifications in the fourth digit too. When I start to count, I cannot see the all the five metacarpals, and uh,
Very good.
yeah.
So
So
what has
and
happened to which one?
so the third one, the ring one, does not is not visualized because there's a good prominent space between the second and fourth metacarpal.
Okay.
However, the carpal arcs appear normal with some reduction in joint space. Um, so, combining the pulmonary features of chest pain and breathlessness and the cutaneous and the musculoskeletal manifestations. So, I would like to put the differential of scleroderma as my top diagnosis for this patient.
What are the joint spaces here?
So, as far as if the metacarpophalangeal joints are concerned, they appear normal. IP joints in the third, in the fourth and fifth digits appear normal, but carpometacarpal joints are normal. Yeah.
And the
So
bone density, what do you think?
bone density is normal.
So when you get this calcification, what you describe as what is called some syndrome?
Yeah. So if I combine all the features, this is the CREST syndrome of scleroderma.
So what it consists of?
So the C is for calcinosis cutis, R is for Raynaud phenomena, um, S, and do not know, remember the more ones. E
Okay.
for,
Telangiectatic and all these things.
yeah.
Okay. So what do you do anything more than that in these cases, or do
So
you?
yeah, I would like to have if pulmonary symptoms are there, to go for a contrast for a non-contrast CT chest, HRCT chest, and perhaps it would show me the esophageal dysmotility. So yeah, in the crest, E is for esophageal dysmotility, and the interstitial lung disease pattern. So to confirm my diagnosis.
Okay. So we do have
Okay, so
a
this is,
barium study. I think it's for the same patient.
yeah. So this is the barium meal, and
What is barium meal or?
barium meal follow through.
Okay, good.
So barium meal follow through, I can
Do you
see.
do any more nowadays?
Yes, in our residency we have done few of them.
Okay.
Yeah. So if I start
Nowadays we do MRI more
yeah,
than this. Okay.
yeah. So if
So
start
you have seen them before, yeah?
yes.
Yeah. So what do you think it is? It shows.
It shows the typical hide-bound pattern of bowel for the scleroderma,
What is height bond?
where the valvulae conniventis are crowded. Not able to see the distal stomach and the pylorus junction well.
Is that something to? Do you get something?
I'm I'm having a suspicion of stricture over here.
Okay. With that previous hand X-ray, and this you still think it is
Scleroderma.
scleroderma. Okay. We can show you some more image of the same patient.
So I've been provided with lateral single projection of knee and shoulder within abduction. Um, so I can see a few medullary intramedullary hyper sclerotic focus with lucency within, corroborative with. But coming to this, in the shoulder, I can see that in the humeral head, some sort of increased density sclerosis with again lucency, a linear irregular lucency within.
What you're
I'm,
trying to,
I'm trying to see for any fractures.
the why
Uh,
this medullary
so
opacities irregular are
it
there.
looks to me like an impression of first was of medullary infarct.
Okay. What about the lungs? Can you see anything in the lower zone or something? It's not a great view. Can you see something in the lower zone? What are these things?
Yeah, so
What
a
is
component of
this?
traction bronchiectasis with
So what do you get these
ring
patients?
shadows with traction
What do you get
bronchiectasis.
these patients? Do you get any changes in the lung?
So if I have to corroborate these findings into a scleroderma patient, yes, then this is the interstitial fibrosis with traction bronchiectasis, bronchiectatic changes.
So lower zone fibrosis, you think is in more in scleroderma, yeah? Lower zone. So you got this patient with both hip pain.
So this is frontal projection of pelvis, but not including both hips. I can see right hip well, but not that of left hip. Um, So there is a component of sclerosis in both femoral heads with few interspersed lucencies. However, the outer contour of the femoral head is well maintained with normal joint space
Very good.
of the hip space bilaterally. I cannot see any definite fracture line, and the rest of the bones appear normal. I'm trying to outline the sacrum and it appears normal. Apart from few phlebolytics, I do not see any abnormality in the pelvis. This could be some bowel gas. So this could be an avascular necrosis in progress, in development, in both the femoral heads, in keeping with,
So is it early stage or
yeah, early stage, because it has not led to the deformity of femoral heads or any collapse or protrusion.
the same patient?
So frontal radiograph of chest of a skeletally immature patient. So I'm trying taking some time to review the through the films. Can see a subtle haziness to both lung fields, and however the cardiomediastinal contour appear normal to me. The bony thorax appears unremarkable. Soft tissues appear unremarkable. Some haziness along the paratracheal region bilaterally.
So what do you think about the bony thorax here?
I cannot see any definite sclerotic or
What
lytic
do you think
lesion.
about the ribs? If you look back, they look normal or
They are more broad,
widened?
widened, yeah. Especially at
Gen,
the junction
gen
of the sternocostocondral junction.
or the posterior end also?
Yeah.
Are they generally wide or
No,
focally wide?
yeah, they in the entire length they are wide.
And
Yeah,
what is the heart size in this for you?
yeah, it's in a proper inspiration. Yeah, the heart side appears a bit enlarged.
Okay, good. So can you link things? Can you think what is this?
Cardiomegaly with um, broadened, widened, flared ribs.
What are you thinking? Roughly why? Is it something hemodynamic? Is something diffuse? What are you thinking? You saw AVN also. Any hemopoietic thing?
That was I was thinking, but I could not see any extramedullary hematopoiesis, any evidence of soft tissue masses in the paravertebral region.
Okay.
It could be thalassemia.
Okay. Anything else? So what do you get in thalassemia? Any other findings? What are other typical things of thalassemia? And what is thalassemia?
So it's basically mutation in the hemoglobin chain.
Yeah. So
Yeah.
what happens? They don't produce.
Enough of good red blood cells for
They need a
oxygenation.
lot of
So
blood transfusion.
yeah.
Marrow is trying to
So hemosiderosis
Marrow is
develops.
trying to produce more, so they get more widened. Is that the thing you're thinking here? Do you know
Marrow
what they get in skull at this age? The skull appearance.
hair on end skull appearance.
Okay. Have you seen before?
Yeah.
Okay. Get a cap.
Yeah, so this is the hair on end and the metaphyseal,
Widening.
yeah,
So same as the rib.
yeah. So
And the bone density.
implying slightly increased, implying
So
marrow.
what is the prognosis of this patient?
So there are different types of thalassemia. If the patient survives, if they are of having a genetic mutation of trait.
And what are the complications of management?
So
Blood
with
transfusion.
repeated transfusions, you get hemosiderosis, and then it deposits into the viscera, into the solid organs, liver, spleen.
Okay, that's fine. It's a bit more than the time, 17 minutes. I think we should stop it. Thanks for giving this exam,
And
and we're grateful for you. You didn't know any of the films, so this is a real exam. And what do you think?
first of all, I would like to extend my gratitude to both of you for giving me this opportunity.
We should extend the gratitude of you coming and sitting with this hot seat.
Yes,
Okay,
I learned a lot, and
and what do you think? How you did?
I have several lacunae which I need to fill in, and I have never
I think you
seen
did
such.
very well. I think you did very well. I think you passed all the exam. This is not same film, but this is related to the same thing. Enlarged heart, widened ribs, so something hemopoietic going on in young age. I think widened rib. This show, if I show you this, this is typical of thalassemia. It will not take much time, but this is one of the film extras you should know that it can be very useful to have this image in your mind. widened rib, because normally you look for NAIs in this case, or rib notching and upper rib, lower rib, but broadly the heart is slightly enlarged. You did very well with description. And this case which we did was CREST syndrome. You knew very well what is CREST. Is a typical connective tissue disorder of scleroderma. You get vasculitis, so that's why you get all this appearance in the GI, narrowing stricture, dilatations. Then lower zone fibrosis is very common, a tenting of diaphragm here, medullary infarcts, which is very important. I think I'm just reviewing it for the sake of people to know. This case is a Aunt Minnie is a spotter. You will get this in the exam. If you get this, this should come out within 1 or 2 minutes because you just clearly define the appearance. Say it is lymphoma and sarcoid. Ask for any any skin lesion, anything, just for getting an idea. And if you say kill it with sarcoid and lymphoma, then you can ask. So I didn't ask you what you'll do. You can ask do a CT scan and staging CT and the management part of it later on, depending on what it is, because both are treatable condition relatively. And but the reason I'm showing you this is the film will come and you will definitely. This was a paraspinal stripe widening, which is also typical of lymphadenopathy. So that's not is vascular, yeah. It is all like lymphatic and nodular thinking, yeah. Thank you very much, and I hope you guys had a flavor of the real exam because the candidate we're grateful. She is preparing for the exam, and I think she did very well considering that the viva is being recorded. She did extremely well. I think she passed this station from my point of view. This is what you can expect, and I think she was hesitant in many films, but then she went through it okay. Some of the examiner may help, some examiners may not help, but she's seen 4 films, and that's okay. That's what it is. This is what the exam is like. We want to give you a flavor of a real exam. This time, hope we'll catch up with some different type of films in the next episode. Okay, thank you very much.